Hi, this is Armando Bosch. I'm a resident at University of Louisville. I'll be talking to you today about a patient with a history of gastric bypass surgery who developed severe neurologic complications. So we have a 40-year-old female with a history of Roux-en-Y, PCOS, ulcerative colitis, lupus, and an unspecified liver disease who was a transfer from an outside hospital for altered mental status and acute liver failure. She was subsequently found to be in septic shock secondary to colitis, which was diagnosed via CT scan. She did have an elevated white count on admission, elevated liver function tests, and a pneumonia of 179. Unfortunately, her mental status failed to improve with supportive treatment, and her ammonia level remained high despite the use of lactulose, zinc, and rifaximin. She eventually required hemodialysis for persistent hyperammonemia, which peaked at 183, and a BUN that began to decline. Because of her history of Roux-en-Y, we obtained a micronutrient panel which showed a significantly decreased vitamin D, folate, copper, as well as zinc, and an amino acid profile which showed elevated glutamine and ornithine with a normal citrulline level. Given her history of gastric bypass, a diagnosis of hyperammonemic encephalopathy from micronutrient deficiency was suggested. So she was started on the appropriate nutritional supplementation, but unfortunately her condition failed to improve and she was transferred to an outside facility to be near family. So micronutrient deficiencies are common amongst patients after gastric bypass surgery. However, it's important for providers to be aware of HAE that can develop, as the mortality is around 50%. This phenomenon is becoming increasingly recognized as many case reports have been published about it. The authors have postulated many different etiologies of hyperammonemia in these patients, including an underlying OTC deficiency that becomes unearthed, an acquired urea cycle deficiency through micronutrient deficiency, L-carnitine deficiency, as well as disturbances in the intestinal wall citrulline synthesis that can lead to the inability to generate urea. In our patient, her amino acid profile suggested the diagnosis of ornithine transcarbamylase deficiency that was underlying. Unfortunately, we were unable to obtain a urine orotic acid, but this level would have been helpful in the diagnosis of OTC deficiency. In conclusion, severe neurologic complications can occur in patients with Roux-en-Y gastric bypass surgery, especially in the setting of infection. So timely recognition and repletion of nutritional deficiencies is important to prevent mortality in patients with HAE.